Broadcast is now starting. All attendees are in listen-only mode.
Good morning or afternoon, depending on where you are. Welcome to our webinar. We look forward to talking with you today about a few of the changes and opportunities that presents for our Medicare Advantage plans from 2021. My name is Linda Roman. I'm Senior Vice President of Strategic Account Management at Centauri Health Solutions. I've been here at Centauri and in healthcare for a number of years, and here at Centauri for over 13 years now. Joining me today is Brian Smith. Brian, if you'd like to introduce yourself.
Good morning or good afternoon, everyone, depending on where you're at. I am Brian Smith. I've been with Centauri Health Solutions for 15 years now. Currently, I am the Director of Operational Planning and Analytics. I have been working in the premium assist space of my entire career here at Centauri Health Solutions.
Thank you, Brian. I think just for the benefit of bandwidth, I will take myself off of camera view at this point so that you can all focus primarily on the presentation. We will get started now. Centauri Health Solutions provides services for payers and providers in both spaces around Medicare, Medicaid, and commercial and exchange plans. Our services are all around reimbursement-focused solutions, so that what we are able to do for our clients is create solutions that lead to higher and more appropriate payment for both the clients and reductions in uncompensated care as well. Our organization, as a result of years of bringing the best of class organizations into the fold, has over 35 years of experience in governmental programs and eligibility and enrollment. We have over 1,700 employees now. We've grown substantially over the past few years. We serve over 500 providers and 70 different payer organizations. Our headquarters are in Scottsdale, Arizona, although we do have locations throughout the country, throughout the United States. So just to give a very high level overview, more from the point of view so that you understand where our expertise lies, is that we do provide services on the left side of this wheel to our provider organizations, Medicaid eligibility and enrollment, out of state, Medicaid, revenue cycle analytics, and referral management and analytics. For our health plan clients, we provide the services on the right side of the wheel. Risk adjustment, quality, HEDIS, dual eligibility, and disability eligibility. Overall, we have over 35 million lives in our data set and under contract, so it does give us a big, broad view of the marketplace. So we will jump right into some of the things that are different in 2021 as a result of new offerings and AEP that is just finished being reported on. In 2021, one of the significant things was that for consumers, there were a lot more choices in Medicare Advantage. More than a quarter of beneficiaries had 10 different plans or more to choose from. You can see on the chart here on the right-hand side of the screen. The average beneficiary had access to 33 Medicare Advantage plans, which is an increase over last year. 77% had 5 choices or more of a Medicare Advantage plan to choose from. And more than 9 out of 10 individuals enrolled in Medicare Advantage will include a prescription drug coverage, or 89%, and 54% of those plans had 0 premium. In 2021, this was a change for 2021. People with ESRD were now eligible to enroll in Medicare Advantage, and special needs plans increased by 14% in 2021. CMS put out some information that indicated that they believe the average monthly plan premium was expected to decrease by 11% on average, which was estimated. Final information is not fully compiled just yet. So another thing that was different in 2021 is many more plans are offering supplemental benefits. 730 plans provided over 3 million Medicare Advantage enrollees with these additional benefits. As you can see on the right, telehealth was one of the significant items that increased this year. 91% covered last year. In 2021, it went up to 98%. Physical fitness benefit, clearly that's a very popular one. Over-the-counter items increased this year as well. 75% of plans offer those. So many additional options were provided for health plans this year. Just demonstrates the competitive environment for Medicare Advantage plans, I believe. So also new in 2021 was the addition of special supplemental benefits. 245 plans offered these benefits in 2020 compared to 831 in 2021. And you can see some of the most common additional benefits here in the chart on the right: meals, food and produce, social needs benefits. Some of those kinds of programs were the most popular that got added. Some writers in the field believed that some changes that were reflected from the COVID pandemic was the addition of benefits relating to anxiety, depressions, and substance abuse. Another factor, however, could likely be that CMS added these disorders to the HCCs in 2020, so it made it possible for more people to add these benefits. So clearly, complete growth in 2021 is not reportable until usually into February. But even in January, the growth looks substantial. Looked like we're going to be at 26.6 million members in Medicare Advantage. Total industry growth of 9.4%. Compared to 8.8% in January of 2020. Again, incomplete reporting. Much growth is still expected to be reported in February. So we'll have a bit of an update to this in our second part of this series. This means that there was growth of over 1.12 million Medicare Advantage members from the new enrollment beginning in 2021. So I think we'll move on to, so what does this mean for you as a Medicare Advantage plan? So clearly it means there are new Medicare Advantage members from which to determine whether or not there are dual eligibles. We need to identify all of those members who may be dual eligible so that they can be categorized appropriately for both the member benefit as well as the plan's benefit. As you can see, it's a very competitive landscape. So the more you can do for your member, the more likely that member is going to have a satisfying experience. So it's really important right off the bat to be able to identify those members and to focus on the right members to ensure that you are maximizing your revenue and getting the benefit to your members that they need. And so we'll talk just a little bit more about the ways in which you can identify those members. And Brian will start talking about a little bit about the ways in which you can identify members, the importance of identifying the right members. So Brian, if you want to take it from here.
Sure, thank you, Linda. As Linda mentioned, it's not only, we're focused on the non-dual population right now and trying to identify who could potentially qualify for dual benefits. And we're also looking at how to maximize your revenue when we do that. So on this slide, what Centauri does here is we do intelligent targeting. So it's not just about converting that member to a dual status. It's counterintuitive, but there are pockets within the CMS payment model where a member is potentially worth more as a partial dual than they are as a full dual. And you can also see this when you're looking at a non-dual versus one of the dual statuses. So the example we walked through here is a disabled female, 40 years old, and she has diabetes and pneumonia. And the first column here is showing you what the full dual coefficient factors are for the risk score. And you can see it totals up to 0.776. As a partial dual, the member is actually worth more. The risk score goes up to 0.908 as a partial dual. So the overall impact, if you had or converted this member to a full dual status rather than partial, would be a downward pressure on the risk score of 0.0132. And what this means basically is using a base rate of $700, the overall payment on this individual member to your health plan would actually be $1,100 higher annually as a partial rather than a full dual. So again, it's almost counterintuitive within the payment model that this happens, but in general, it's about 5 to 8% of the population within the Medicare Advantage plan. You're going to see this scenario play out. So what we do in our targeting, we're going to drop those folks to the bottom of the list, and we will actually coordinate with the plan and do the prioritization there. Work with you, determine, do you want us to target these members or not? Now, as far as finding overall new duals within the population, we use a predictive model, fairly standard in the industry at this point. But where we think we have some differentiation from our competitors is our model, our latest version, we have found that we can identify 99% of the dual population within what we call the top 4 cohorts or deciles of our scoring model. That doesn't mean that every single plan is going to have 40% of their members hit in those top cohorts. It all depends on plan benefit package design, premiums, and some external variables and other internal variables that we apply there. But overall, our model, we have found across the nation, we can identify 99% of the duals within those top 4 cohorts. So this helps us help people faster. It helps us help more people. We're going to prioritize. We're going to work the non-dual population, going after those most likely and highest value first in our outreach efforts, and then work our way down through our scoring model. And then again, we will coordinate with our partners and customize that outreach for your demographics and your geography.
So, Brian, thank you for showing us the ways in which targeting can be effective to finding the duals. In the information you shared before about the anomaly, is that anomaly frequent or is it infrequent? How do you find that fits in the total mix?
Yeah, it's relatively a smaller portion. It's generally 5 to 8% of the population within an MA plan. It will depend on, the plan specific demographics for the membership, but it's about 5 to 8% of the members that potentially hit that bucket.
Okay, so all the more reason to really be familiar with and understand exactly how each member's HCC codes and their category really affects the outcome, and being able to properly stratify the members to know who the right duals are that are going to maximize the revenue for you, correct?
Exactly. Yep. It's all based upon that combination and interaction of those HCC variables that will drive what the ultimate revenue will be if you convert somebody from non-dual to a dual status.
Perfect. So we have this 1.12 million additional Medicare Advantage members this year. And so the next most important thing is to find the right people to make sure that if they are eligible for a dual category, that they get moved to that. And this type of predictive analytics is a way to identify the right people. Then, of course, you have to do the outreach and work with the members to get them qualified, but certainly having a way to clearly identify the right members is going to be a critical step in the process.
Knowing who to target and how to target them is extremely valuable information. You don't want to waste your time doing a lot of outbound calling to people who aren't going to be eligible.
Great.
So this slide here is speaking for those, hopefully everybody is fairly familiar with the model changes that CMS made back in 2017. The move from the prospective payment model for 2016 and prior to the concurrent payment model that is now in place. The current model for 2021, it is weighted 25% now on the 2017 factors versus 75% on the 2020 model factors at this point. But in general, what those changes meant for health plans relative to converting members to dual status was prior to 2016 or 2016 and prior, your dual status did not matter. If you were a full or a partial, the health plan was going to get, on average, a bump in their capitation payment of $125. 2017 forward, CMS changed that entire model. They had determined that health plans were getting underpaid for their full dual population and overpaid for the partial dual population. So based on 2020 data now, we are looking at the average increased revenue when you convert somebody from non-dual to a full dual status. That average increased payment has gone up to $225 now. And then on the partial, this is the third bullet here, that payment is now on average $45. And these are going to depend on your bid rates and so forth, but this is just in general on average what we've seen. The middle bullet there is a key important variable. You want to keep a close eye on your agents. The reason being, the agents don't have experience yet, and they are not going to be paid based off the community model yet. They are paid strictly on their new to Medicare factor. And that factor does not matter if you're partial or full. So on average, if you can convert somebody who's new to Medicare, convert them to a dual status, that overall increase in payment is around $335 per member per month. And you'll get that payment for 12 to 18 months until that member has enough experience where they are then converted to the community payment model. And the last key point here relative to what Centauri has seen with our non-dual outreach and converting members to dual status is we create a stickier situation for that member. By that, we mean that member, on average, excuse me, is going to maintain enrollment within your health plan for nearly twice as long as members that are either non-dual or dual that we have not assisted.
So, and that's certainly important, Brian, in this competitive environment. It's important for that stickiness. So that seems like a very useful piece of information as well.
Exactly, Linda. It's not only maintaining that increased capitation, but the overall payment that the plan is receiving for that.
Perfect. Perfect. Thanks, Brian. So we will, another component that seems very important and increased, of course, this year, as we mentioned early, was the addition of other supplemental benefits. And so one of the things that we have have worked on with many of our health plans is the addition of these supplemental community-based programs that impact the social determinants of health. And so because the members that we work with, the dual eligibles or the potentially dual eligibles, are the higher need, higher risk score, kind of more complex member, we determined that in fact those are the exact members who may benefit from some additional community-based programs. And so for those of our clients who have opted to use this service, what we're able to do is identify through a brief social assessment for those members who want to participate, and recommend additional community-based resources, whether it be, getting them onto food stamps if they qualify, or getting some housing or utility assistance for the member, or identifying some community-based support groups. These kinds of programs, again, demonstrate that the health plan is looking for any and all opportunities to help the member in a variety of ways. And so it just adds to the programs that the health plan is bringing to a member. Once we identify through this social assessment the member's needs, then those items are reported back to our partners, and identified resources that we've been able to find to try and get them the support they need in the community. What we have found, very much like the chart, maybe the chart you saw earlier, is that one of the highest needs is the food need. Food insecurity and the need for nutritious food is one of the highest areas that we've seen as needs that get identified. Over 26% of the needs identified in our social reviews tend to be around food insecurity. Housing is certainly a very high one as well, at 31.87% of our individuals who get assessed identify a housing need, whether that be some utility support or different housing or insecure housing, a variety of different factors there, where we're able to help them identify resources within the community to try and support them in those needs. Social supports, financial supports, transportation is a lower one because many plans include certain components for transportation. So you can see there in the chart the kind of the variety and categories of services that people have identified through our social assessment component. In addition, as you can see here, what we're able to do then is record that information and share it back with our partners so they can see exactly what kinds of needs a particular member has. Part of the process that we undertake also is reaching back out to the member to make sure that they got the additional social supports. Sometimes some of the community-based programs, because they're grant funded, sometimes they do occasionally run out of money in the middle of a month. And so if that has occurred, then we're able to look for additional resources for a member. But one of the things that I think is really important here is the fact that this information then is available to the plan in case management, so that they also know what needs have been identified and what supports have been provided to the member as well. So, in a competitive environment, all the possible options are important in getting services to members, providing members with the evidence of the way in which the health plan is supporting them and creating that stickiness that Brian was talking about, that the folks that we end up working with in these different programs, both in the dual outreach program as well as in the social determinants program, which we call Social Services Plus, provides those means that really do impact the overall retention rate of those members in addition to the benefit retention. So, just kind of in summary, these kinds of programs are important in identifying those new duals that have maybe come into your plan but aren't on the program yet. It's important to target those members so that you are reaching out to the right members. We certainly have had a lot of experience in doing so, work with a lot of health plans throughout the United States. I believe we work in almost every state in the country, perhaps except Puerto Rico. We do some things also that such as some of the Medicare Advantage members become eligible periodically, and there may be spend downs, and these rules are different in every state sometimes. And so really understanding and working with the member on their spend down, however frequently that occurs for them, is an important component and a way in which we always support the members as well. That allows them to maintain their benefit over the long term, as opposed to sort of going on and off of the benefit. So one of the things we didn't really talk very much about today is the retention of those members once you have them in your plan, and once you've identified them and gotten them into a dual program. And that's going to be the subject of our next session that we're going to do on March 18th. At that point, we'll have a little bit of an update on membership, because we do expect more numbers out in February, and we'll perhaps have just a little bit more information. We won't go through the entire kind of differences, but we'll just do a little bit of an update there and talk quite a bit about retention and the importance of a proactive retention strategy as well, to make sure that you're protecting those benefit statuses so that it protects your revenue as well. So we would look forward to you coming back and sharing another 30 minutes with us in March. If you would be interested in doing so, we would welcome the opportunity to talk with you then. So thank you very much. I don't see any questions in the message board, and so we will end the session here at the half hour, and appreciate everyone who attended. Thank you so much for your attention. Have a great afternoon. Thanks, Brian.
Thank you, everyone.